I am Dr. Heather Hirsch. If you don't know me, I am the lead physician of the Menopause and Midlife Clinic at the Brigham and Women's Hospital in Boston, Massachusetts. And we are still social distancing, which means that I am doing telemedicine visits from my home. And I am also continuing to film some new YouTube videos for you. So please like and subscribe and hit that bell notification so that you can always see my new videos when they come up. Now, you can also follow along with me on Instagram at hormone.health.doc and my Twitter, which is Heather Hirsch MD, as well as follow along on my website, heatherhirschmd.com, where I have my menopause course, the complete guide to menopause, everything you ever wanted to know your doctor never told you, and my new ebook, which is a journal and workbook in one, and it provides a great way for you to talk to your physician about your menopause journey and help you get treated. So this much requested video is all about the safety and efficacy of hormone replacement therapy or hormone therapy. It has two different names. The slang name, HRT, really actually means when you give physiologic hormones to a woman who has menopause before age 40, and hormone therapy is when we give hormones to women undergoing natural menopause, which is in the United States around age 51 and a half. So in this video, we are going to do a Cliff Notes version of the safety and efficacy of hormone therapy. Now, there is a lot to learn about this topic. I actually have a great podcast episode on it that I am also going to link below, so that if you want to listen to it again in even more detail, I will link that episode down there. So I want to start off with, back in the 1980s and the 1990s, it was really commonplace for physicians to give women estrogen shortly after menopause. And they found that women did really well. They had less heart disease, they had improvement in bone health, they didn't have menopausal symptoms. And so really, the American College of Physicians in the 1990s recommended as first line hormone therapy for women very shortly after menopause. Now, menopause is a year of no periods, and we'll do a whole video on how to tell if you're menopausal, because that is not as easy as the textbook says that it is. So in the 1990s, as this was really getting to be seen that women were doing well with estrogen replacement shortly after menopause, it was decided that there was not yet a randomized control trial or a randomized controlled study on hormone replacement in women after menopause. So for those of you who are, new to scientific lingo, the gold standard of knowing something is safe and effective is to do a randomized controlled trial. So they did one, because all they really had in the 1980s and 90s was prospective studies, essentially just giving medication to women and watching how they did. So in the mid 1990s, they set up, or doctors at the time set up, a really, really large study called the Women's Health Initiative, or WHI for short. You have definitely heard of it, whether or not you knew it was the WHI, because this study is what made a lot of news coverage. Okay, so what is the WHI? They took hundreds of thousands of women all across the country in different big institutions. And what they did is they made a couple groups, but I'm going to break it down as simply as I can. The two big groups were women who had a hysterectomy and women who still had their intact uterus. And among those two different groups, they split them off into two more. So if you had a hysterectomy, they gave some women estrogen and they gave some women placebo. And they didn't tell them, of course, the physicians didn't know which one they were getting. That's what makes it a randomized, a controlled trial. Now, if you have had a hysterectomy and you no longer have an intact uterus, you can take estrogen only. The main role of the progesterone is to protect your intact uterus. So if you no longer have it, most commonly you do not need to take a progesterone. Over here, the women who still had their intact uterus, they split them up into estrogen plus progesterone and then estrogen plus progesterone placebo, meaning they were just getting sugar pills and these women were getting hormones. but they were all blinded. So nobody knew which medication they were getting, and the physicians didn't know which medication they were getting, because this is the best type of study to determine if something is really safe. You compare it to placebo and you randomize and you get out any compounding factors that you can. Okay, so now, what was very interesting about this study, and what I teach my physicians when I do this presentation, is that the average age of the woman in the WHI was age 62 to 63. That is really important because the average age of menopause in the United States is 51 and a half. Now, let's go back to the average menopause, natural menopause. Some women are in their, late 40s, some women are in their late 50s, and that's sort of the bell curve of normal, okay? What's considered abnormal, and we'll do other videos on that, is premature ovarian insufficiency, used to be known as premature ovarian failure, which is menopause before age 40, and then early menopause, which is menopause between ages 40 and 45. So this means the average age of the woman in the Women's Health Study was about 12 to 13 years post-menopausal. And in fact, the spectrum of women was from age 51 to 79. So there was a big physiologic difference in these age ranges of women. Okay, so that's really important to fact number one, is that the average age was older than natural menopause. Number two, this study was not designed, its primary endpoint was not to look at control of menopausal symptoms. You'd think that it was, that would be like, just, make the most sense, but it wasn't. It was to look at, the primary endpoint was to look at heart disease in women. So they wanted to see, was estrogen preventing heart disease? So the way it was powered and the way women were recruited was a lot different than if they were looking at controlling the symptoms of menopause. So the primary end outcome was looking at all-cause mortality and heart disease, and then secondary was strokes, and then bones and some other things. Only a small percent of the women in the study were symptomatic, meaning they had, either symptoms of hot flashes. I forget the number, but I want to say it's about 17% of women. I usually have this memorized on the top of my head. I think about 17% of women were symptomatic. So you have to understand that the population of women they were looking at was completely different than the population of women in the late 1980s and early 1990s, when they were giving women estrogen shortly after menopause, and typically those who had symptoms. So already there is a disconnect. Okay. Now, after about 5 years of the study, in 2002, the estrogen plus progesterone arm, women who had an intact uterus over here, this arm got closed. And that's because there was found to be an apparent increased risk of invasive breast cancer in this arm. And that really crossed the study's threshold for safety. Now, the media reported this as a 24% increase in invasive breast cancer in this group of women, which sounds really scary. But the problem is, relative risk only makes sense when you're looking at the population of women. When it is a really small percentage or really small actual numbers, the relative risk really, though, can look a lot bigger. So what were the numbers? Okay, I'll tell you. In the Women's Health Study, when the study ended in about 2002, 2003, it was an extra 1 or 2 to 4 cases of invasive breast cancer in over 5 years of women taking a medication called PremPro. So actually, I forgot to tell you the medication names and the doses that they used in the WHI, so I will come back to that in a second. But because of the apparent increased risk of invasive breast cancer, the study was stopped, and that's when the media just really, went crazy over this data point, which, is something that is hard to undo. So before I get into that story a little bit more, I do want to tell you the medication they were studying, because that really also matters. So the medication used in the Women's Health Study was Premrin 0.625 of conjugated equine estrogen, or it was PremPro, which is conjugated equine estrogen 0.625 plus, I think it was 2.5 milligrams of medroxyprogesterone acetate in one pill. Okay, so I said over here, this is the women who have an intact uterus, they took PremPro, and the women who did not have a uterus, who only took estrogen because Again, no uterus, no need for progesterone. We're taking just the Premarin, okay? So it just got to the point where they found there's an apparent increased risk of invasive breast cancer. So this arm was stopped. And about a year later, they also stopped this arm. But what is really interesting, and what I correct physicians on, or residents in training all the time, is this. The women who took estrogen only actually had less breast cancer than the placebo. And this persisted for many years. And we'll come back to that because this data was looked at years and years later. Okay, there was an apparent there's an increased risk of invasive breast cancer in the estrogen plus progesterone arm that equated to 2 to 4 women out of 1,000 over 5 years who took Prem Pro. Now, that does seem really kind of frightening, but it's fascinating to scientists and doctors and researchers that the women who took estrogen only had less breast cancer. Like, that fact seems to sometimes go ignored. Now, this over here, there's a lot of, this is a complicated issue and is very, very complex. But I want to break this risk down for you because it's actually quite small. The risk of breast cancer being obese is much higher than the risk of taking Prempro for 5 years. The risk of having breast cancer in general is 1 in 8 just by having breasts, which, you know, is what it is. It's similar to men and prostate in some ways. They have a prostate and they have high risks of prostate cancer. There is always going to be a risk that is fairly, substantial in the population of getting breast cancer. And it's not to say that it is not important. It is never anything that I'd want any patient to have to go through. But the risk overall is actually really quite low if you are suffering daily, if your quality of life is really suffering from menopausal related symptoms. So let's get back to the data, okay? So in the women's health study, when the data came out, there was also an apparent increased risk of stroke and heart attacks, which scared a lot of people. But it wasn't until they did post hoc data analysis, which means years later, they took that data and sort of dissected it out, that they saw some really, really interesting facts. And here's where we come to the timing hypothesis. So they broke the women down into 3 different groups. First, they broke the women down into ages of 51 to 60, or within 10 years of menopause, which I personally like better because, again, menopause could be age 53, it could be age 48, and so I use years since menopause as opposed to just your age 51 to 60. But they did 51 to 60, or less than 10 years from menopause, women who are 60 to 69, and then 70 to 79. And what they found is that the women who are within 10 years of menopause had many benefits. They found that they had improvement or less heart disease. They died less from all causes, meaning they had lower mortality. They had improvements in quality of life, improvements in sexual function, improvements in brain function, improvements in bone health. Of course, it stopped hot flashes and other bothersome symptoms and tended to do really, really well. And the reason that this is super important is because you can't just look at one thing and say, the risk of breast cancer is so small, but I can't take it. If you also expand that to think about, this is really good for your heart health, which is the leading cause of death in women in the United States. This is really good for your bones, which more women will suffer an osteoporotic fracture than they will heart attack, stroke, and breast cancers combined. This is really good for my daily quality of life, which is so, so important. My productivity, my job, my family life, my friends, my partnerships. And so it's really a global, risk benefit that you want to think about. And it is particularly safe, again, for women who are within 10 years of menopause. Now, this is not to say that if you're in the 60-year age group, or if you're older than 60, maybe in your 70s, it's just a very different conversation about risks and benefits. And I definitely want to make the point that this also means the age at which you start. It's not an accumulating risk every year that goes by. This is also a thing that I correct physicians on all the time. The biggest risk is not breast cancer. The biggest risk is the rare risk of a blood clot. It's about 1 in 1,000 if you take oral. It's about 1 in 2,000 or less if you take it transdermally. Those are overall, still, we overestimate that risk. Overall, it's still quite low. But the risk is highest. Sorry if you can hear my dog barking. I know I'm at home and there's just so much going on. The risk is highest in the first 6 months. After that, if you have done really well, chances are that you are going to continue to do well on that medication for as long as you need it. So this is something that I correct other physicians on all the time. This has to do with the age at which you start, and then you are, those rules kind of continue to apply. So the timing hypothesis says you've been out of menopause for 2 years, we start you on hormone replacement, you do really well, you get out of the 6 months, then we sort of know you are not at very high risk for a blood clot because you've done so well for 2 years. We can continue it as long as you think that you need. Now, this is a ton of data. I know it is a lot to take in, but since the WHI, they have done this post hoc analysis looking at this data in 2007, in 2013, again in 2017, and I think there's going to be another one coming out soon, again, really demonstrating that women who did take their hormone therapy that were in the first 10 years since their last menstrual period continued to do well. Even when they took it for those 5 years, they still died less from all causes. They lived longer. They had less heart disease. They had better bones, and many, many, many things. And that's just one study. There is many other studies, all really looking and showing that same thing. Really, the timing hypothesis that this, if you take hormone therapy within 10 years of menopause and you have no known contraindications to estrogen replacement, the safety data is really, really strong, especially when you compare this to other medication. Almost every medication has a risk, right? There's no medication that is risk-free. An antidepressant has side effects. Aspirin and NSAIDs can cause bleeding. Insulin can cause hypoglycemia, can cause people to end up in the emergency room, right? Every medication does have some risk. Estrogen is no different than that. And we just do tend to sort of overestimate the risks or really scare women that hormone therapy is unsafe. And that is simply not true. There is other studies that I point to when I'm with my patients face to face, and I go over a lot of this as well in my course. There is something called the DOPS trial, the Danish Osteoporosis Prevention Study, and the KEEPS trial, the Kronos Early Estrogen Replacement Study, both looking at younger symptomatic women, which again, very different from the WHI population. Again, showing that estrogen therapy, when given within 10 years of menopause, really has many benefits in terms of heart health, bone health, even brain health. We're doing more research in that area. But again, you see anecdotally and in my clinic, people, in terms of their brain function, they feel like that brain fog is relieved. They feel like they can work and be productive and not miss things like they were before. Sleeping improves, and overall chronic diseases improve. In fact, even insulin resistance and insulin sensitivity improved, which means that there was a less progression to diabetes to women who took hormone therapy in the WHI and in other studies compared to women who didn't. So it really, you have to sort of look at this as, what are the risks to taking hormone therapy and what are the risks to not taking hormone therapy if you really need it? So there's plenty of data that allows me to feel very comfortable prescribing and consulting my patients on the use of hormone therapy. If you have more questions, if you want to learn more about this, I highly recommend my course, The Complete Guide to Menopause, which I will link below, as well as my podcast so that you can listen to this a couple of times. There is so much information on the safety of estrogen. And again, if you have an intact uterus, you also need to take a progesterone. And, more data has also come up about that progesterone component. And since the WHI, a lot of other studies have been done looking at different types of estrogens, different types of progesterones. Is it better in a patch? Is it better if we use more bioidentical, which is a slang term? It just means that it's more of a natural than versus a man-made type of progesterone. And there's so much data. So that really, if you are the kind of doctor like me who really focuses and reads and gets down to the nitty-gritty about menopause, research and science, you do feel very comfortable prescribing hormones because overall they are quite safe. And again, no different types of, risks than other types of medications that, internists and gynecologists are used to prescribing on a daily basis. So much data out there. I'm going to do another video on the different types of progesterone to follow up on this. So send me questions, comments, things that you want me to go over. I'm really, really excited to do that for you. Don't forget to like and subscribe if you liked this video. And I promise you soon, when we are not under quarantine, I will be back in my office without the dog barking in the background, without the pitter patter of my kids downstairs. I hope they didn't bother you too much in this video, and we're all in this together. Have a wonderful day or evening. Stay inside and stay safe. Bye.